Hello everyone, I hope you're all doing really well. I've got the TOG articles from the April 2023 TOGs that were remaining from my first video, so I'm just covering those rest of the TOG articles here. I hope you find this video useful, and if you do, don't forget to give it a thumbs up and also subscribe to my channel if you haven't already. So this is a TOG article titled Consenting, Competence and Confidentiality in Pediatric Adolescent Gynecology. So adolescence is a stage of human development between childhood and adulthood. Confidentiality is obviously fundamental for good quality patient care. Who can give consent for a young person? So a young person over 16 years of age or under 16 years of age can give consent if they are competent. A parent or an individual local authority with parental responsibility or court can give consent on behalf of the young person. Okay, so the 7 principles to follow to obtain informed consent. Number 1 is all patients have the right to be involved in decisions about their treatment and care and can be supported to make informed decisions if they are able. Number 2, decision making is an ongoing process focused on meaningful dialogue, the exchange of relevant information specific to the individual patient. Number 3, all patients have the right to be listened to and to be given the information they need to make a decision and the time and support they need to understand it. Number 4, doctors must try to find out what matters to the patients so they can share relevant information about the benefits and harms of proposed options and reasonable alternatives, including the option to take no action. Number 5, doctors must start from the presumption that all adult patients have capacity to make decisions about their treatment and care. A patient can only be judged to lack capacity to make a specific decision at a specific time and can only only after assessment in line with legal requirements. Number 6, the choice of treatment or care for patients who lack capacity must be of overall benefit to them, and decisions should be made in consultation with those who are close to them or advocating for them. Number 7, patients whose right to consent is affected by law should be supported to be involved in the decision-making process and to exercise choice if possible. Points to consider while assessing the best interest of the adolescent. So number 1, views of all the adolescent. Number 2, views of the parents or the person with parental responsibility. Number 3, views of others close to the adolescent. Number 4, the cultural religious beliefs of the adolescent and their parents / person with personal responsibility. Number 5, views of the other healthcare professionals caring of the adolescent. Number 6, the least restrictive choice for the young person's future options. Points to consider while communicating with an adolescent. Number 1, involve the adolescent in the discussion. Provide open and honest information to them and their parents or the person with their parental responsibility. Respect confidentiality. Respect their views, opinions, and concerns. Simplify and explain in language they can understand. Be mindful of the surroundings and nonverbal cues. Encourage them to ask questions and give honest answers. Do all you can to make open and truthful discussions possible, taking into account that this can be helped or hindered by the involvement of parents or other people. Provide the same respect and time you give to adults. So, assessing capacity to consent. Understand the patient should be able to understand the proposed treatment, understand the benefits, risks, and alternatives, including the option of not having treatment, believe the information applies to them, understand, retain, and weigh the information, and communicate their decision to others. Choose without pressure. So in UK in 1983, Gillick competence was passed. This allows patients, adolescents who are under 16 years of age to access medical advice and treatment without parental consent. So understanding and knowledge of treatment and process involved, benefits, risks, and alternative options. So adolescents who lack capacity to consent in England and Wales and Northern Ireland, parental responsibility can consent in the best interest of the 16 and 17-year-old who lacks capacity for investigations and treatment. In England and Wales, treatment can be provided in the adolescent's best interest even without the consent of the parents or the person with the parental responsibility, although their views are important in assessing the children's best interest. In Northern Ireland, treatment provided can be provided in the young person's best interest if the parent or the person with the parental responsibility can't be contacted. For significant interventions, legal advice should be sought unless it's an emergency. In Scotland, adolescents of 16 and 17 years of age who lack capacity to consent are treated as adults who lack capacity to consent, and treatment can be provided to safeguard and promote health. So Jehovah's Witnesses are patients or the particular sect or belief of people who do not accept blood transfusion. It's important to understand this, and so parents who refuse blood products for their children based on religious grounds, the child's best interest is paramount, and hence blood can be given. However, consideration should always be given to the view of the parents or those with parental responsibility, and it is preferable to seek legal advice in these circumstances. If there is conflict, then the action favoring the child's best interest should be done. If a competent adolescent is refusing blood in a life-threatening emergency, the same principle can be applied as in an adolescent refusing a life-saving treatment. So contraception in adolescents, young person under 16 years of age without the knowledge or consent of the parents can use contraception if they can understand the contraceptive advice and its implications. If the healthcare professional could not convince the young person to tell the parent or to allow the healthcare professional to tell the parents, the young person is very likely to continue sexual intercourse irrespective of the contraceptive advice. Withholding contraception could harm their physical or mental health. Right, the clinical implications of interventional radiology techniques in obstetrics and gynecology. So uterine artery embolization is injection of a permanent occlusive agent into the uterine arteries to cause ischemia of the fibroids. So it's done under conscious sedation. Takes about 30 to for about 30 to 90 minutes. A small scalpel skin incision is made at the groin to allow vascular access to the femoral artery. Through the femoral artery, access is gained into the internal artery and then the uterine artery, and then a permanent embolic agent, which is, for example, polyvinyl alcohol particles, are injected into the vessel and as close to the fibroid as possible to avoid non-target embolization. Ovarian uterine anastomosis can happen in 46% of women and are independent risk factor for procedure failure and post-operative ovarian insufficiency. So contraindications to uterine artery embolization for fibroids. Absolute contraindications are current or recent pelvic infection, pregnancy, asymptomatic fibroids, women for whom the small risk of requiring a hysterectomy in the event of a complication is unacceptable, or event of complication. Significant doubt about the diagnosis. Relative contraindications are desire to preserve fertility, larger fibroids, pedunculated submucosal fibroids, larger intracavity submucosal fibroids. Complications of uterine artery embolization for fibroids or adenomyosis. So immediate complications can be groin hematoma, arterial thrombosis, aortic dissection, pseudoaneurysm, reaction to the contrast media, spasm in uterine artery leading to incomplete embolization, non-target embolization. Early complications within 30 days could be post-embolization syndrome, so pain, fever, nausea, malaise, raised vitals, or it could be urinary tract infection or deep vein thrombosis. Late complications, so beyond 30 days, vaginal discharge, fibroid expulsion, endometritis, sexual dysfunction, amenorrhea or non-target embolization, resulting in ovarian infarction secondary to the ovarian uterine anastomosis. Complications of ovarian vein embolization for pelvic venous congestion syndrome. So immediate are complications relating to sedation, hypersensitivity to the iodinated contrast, related to venous puncture, so hematoma, pneumothorax, non-target embolization like coil migration, stroke, early complications within 30 days, enlarging pneumothorax, coil migration, pulmonary embolization of coils. Complications of percutaneous drainage of collections. So procedure related are pain, syncope, sepsis, gastrointestinal perforation, nerve injury, hemorrhage, hematoma, failure to drain the collection owing to content of collection, so necrotic material, loculated collections, high viscosity fluids. Catheter related could be obstruction, malposition, dislodgement, kinking, inappropriate catheter size, premature removal. So for interventional radiology techniques in obstetrics and gynecology, so there is vascular interventions, there's non-vascular interventions. So vascular are uterine artery embolization for adenomyosis, fibroids, ovarian vein embolization for pelvic venous congestion syndrome, devascularization for major hemorrhage, so major obstetric hemorrhage, gestational trophoblastic neoplasia, ectopic pregnancy, uterine arteriovenous malformation, gynecological malignancy, or management of DVT and PE. Non-vascular are things like magnetic resonance guided focused ultrasound for fibroids, thermal ablation for gynecological malignancy, management of ectopic pregnancy, fallopian tube recanalization, drainage of tubovarian abscess, post-operative complications, and ascites. So this brings us on to the last article in the April 2023 TOGs. I hope by far you've enjoyed all the summaries so far, and if you have, then don't forget to hit the like button and subscribe to the channel if you haven't already. So prenatal genomic testing for ultrasound detected fetal structural anomalies. So fetal structural anomalies are present in 3% and 5% of pregnancies. Chromosomal or genetic problems are associated with 40% of the fetal structural anomalies identified from quantitative fluorescence polymerase chain reaction, G-banding karyotype, and chromosomal microarray. So karyotype is a gold standard for detecting mosaicism, polyploidy, and rearrangements like translocations and inversions. So clinical examples where rapid fetal exome may be appropriate and suggested in exclusion criteria. National Genomic Test Directory of April 22, NHS England. So inclusion is fetuses with multiple anomalies, suspected skeletal dysplasias, large echogenic kidneys with a normal bladder, major central nervous system abnormalities, multiple contractures, nuchal translucency of greater than 6.5 millimeters plus another anomaly, isolated non-immune hydrops fetalis. Exclusion criteria is confirmed, aneuploidy or pathogenic copy number variant consistent with fetal anomalies detected by microarray, minor markers of aneuploidy, fetuses with confirmed atropic dysplasia, cases where familial causative variants are known, where sonographic findings indicate a specific monogenic disorder, where termination of pregnancy has already been decided, or when fetal demise has occurred or is imminent. Thank you so much for listening. I hope you found this video useful, and if you have, then please hit the subscribe button and also the like button, and leave any comments of any other suggestions that you would like summaries for before your exam. Good luck revising.